Welcome to Health Politics with Dr. Mike McGee, a weekly program exploring important trends in health.
If you think America's inability to effectively address its problems with the uninsured is insolvable, think again. Some recent developments are beginning to undercut that myth. That said, it's no secret that traditional health sector leaders, including health insurers, have been unsuccessful in providing broad, reliable, and equitable health insurance coverage to U.S. citizens. Not only has the number of uninsured increased, but quality of coverage is declining as rates of medical bankruptcies are rising. Is a lack of financial resources the problem, you ask? Not really. It might surprise you that a close analysis of the numbers actually suggests that the problem is fundamentally related to organizational inadequacies, not a lack of financial resources. And there are organizations out there who have the tools to help us get out of this mess. But first, let's take a look at the numbers. There are approximately 290 million U.S. citizens. 244 million, or 84% of them, have health insurance, and approximately 46 million, or 16%, are uninsured. Now, that 46 million number pertaining to the uninsured is somewhat misleading on three counts. First, it includes only those without insurance for 12 months. If you count all who went without for at least 1 month in 2005, the number jumps to 64 million uninsured. Second, it says nothing about the quality of the insurance. And as insurers and employers are rushing to embrace consumer-directed health plans with high deductibles and health savings accounts, the risk of losing it all is rising for the American family. Third, the number doesn't include an estimated 7 to 10 million illegal immigrants who function in the U.S. under the radar screen, arriving at the nation's emergency rooms when they're sick and desperate. Now, of the 244 million insured U.S. citizens, 174 million, or 60% of the total population, receive insurance from an employer. This has been a problem for a long time. First, it's expensive for the employer, a point that has been accentuated by the emergence of highly competitive global trade. Second, if you lose your job, it's a double whammy. No income and no health coverage for you or your family. Third, under pressure or contract to provide the benefit, employers are susceptible to short-term strategies to control their costs, which can be a detriment to long-term investment in prevention, especially when they embrace skimpy plans under the guise of consumer-directed health care. Now, where else is coverage coming from? Some 40 million Americans, or 14%, receive Medicare coverage. 13% are covered by Medicaid or S-CHIP plans designed for low-income citizens, and about 4% are covered by the military or VA plans. So that leaves about 6% who purchase plans on their own, either for primary coverage or as secondary or supplemental protection. Now, let's further break down the numbers associated with the uninsured. Out of the 46 million who have gone a full year without coverage, 53% have earnings below 200% of poverty. In 2004, that was $18,620 for an individual and $37,700 for a family of four. Only 25% were at or below poverty levels of $9,310 for an individual and $18,850 for a family of four. More telling, though, was the fact that 28% of the uninsured had incomes above 300% of poverty, including 11% whose incomes exceeded 500% of poverty. The message here? Number one, not all of the uninsured are poor, at least by current definitions. But this is not to say that they are either well or invulnerable. They may be unable to get insurance because of prior medical conditions. They may be overwhelmed by other financial liabilities. Or they could be risk takers who feel that they can get away with not having health insurance. Number 2, if you are poor, it doesn't necessarily mean you're eligible for Medicare or S-chip. Eligibility is not simply a function of income level, but also population category. And the rules vary from state to state. But in general, children receive the top priority. Disabled and impoverished seniors are second, and parents of dependents third. Childless adults are hardly ever covered. One can see this reflected in the overall numbers. While childless adults account for 45% of the total population, they're responsible for 57% of the total uninsured. Now, what else do we know about the 46 million uninsured? 21% are under 18, 19% are age 18 to 24, 22% are 25 to 34, and 37% are 35 to 64. The uninsured are more likely to be white than any other race, but rates are significant among Hispanics partly because of the high rates of non-citizenship. 79% of the uninsured are citizens, 21% are non-citizens, which approximately half of these are estimated to be illegal immigrants. About 46% of the uninsured work for firms with fewer than 100 employees. 46% work full-time, 28% work part-time, and 26% do not work outside the home. As I mentioned earlier, a lack of funds is no longer a viable excuse for this massive problem. Careful and deliberate economic studies have revealed that the current public dollars spent on coverage for the vulnerable, support of uncompensated care, and safety net infrastructure exceeds what would be necessary to actually insure all of the current uninsured. Thus, an increasing number of experts believe that what we call a crisis is in fact mismanagement on a massive scale. The waste is a function of ineffectual information and financial systems managed by middlemen used to draw in high profits for poor service. We lack an advanced information infrastructure that would expand connectivity, reliability, and safety. And we often fall prey to the seemingly impenetrable array of traditional silos born from outdated systems and supported by perverse subsidies and incentives that are taking away assets that could be used to invest in a preventive healthcare system. It's time to let new, untainted players pick up where health leaders have left off. Experts in technology and finance are coming to the forefront. Need assets? They say no problem. We've got them, and we'll gladly invest them to enter the healthcare space. Need IT expertise? New convergent devices? Broadband? Wireless loops from home to care team to home? Why not? That's our business. Need to bring order out of confusion and balance transparency with privacy? We've done it. And we'll do it for a fraction of the cost your insurance company charges because we'll book income from investments and other sales and services not specific to health. And oh, by the way, for the privilege, we'll throw in some help to cover those 46 million uninsured, and we'll do it for a rate far below the current subsidies to your broken safety net. Just a way of saying thank you for introducing us to all these new customers. Imagine that. For Health Politics, I'm Mike McGee.
Thank you for watching Health Politics with Dr. Mike McGee. If you are accessing Health Politics with a portable device, please visit our homepage, healthpolitics.com, for more information on this topic and many others. If you are watching Health Politics on the Internet, please visit the links below for additional information. Download the transcript and slides to share with friends or colleagues, or use the discussion guide to help generate conversations in the classroom. If you are not yet a Health Politics subscriber and would like to begin receiving a weekly email to keep you up to date on our latest programs, please click on Subscribe to Health Politics above and enter your email address. Again, thank you for watching Health Politics with Dr. Mike McGee.